Sure, I will present our next speaker is Dr. Hatim Lawati from Muscat, Oman, and he will present a DK crush left main case. Go ahead.
Thank you.
Hello and greetings. I'd like to thank the organizing committee of the Gulf Interventional Society for inviting me to share my experience with this intriguing case of distal left main bifurcation that we ended up treating with a double kissing crush technique. My name is Hatim Lawati, and I'm from the Sultan Qaboos University Hospital in Oman. Our patient was a 75-year-old frail lady who was a type 2 diabetic and dyslipidemic, who for the first time in mid-December of last year presented with a non-ST elevation acute coronary syndrome. Her troponin at that time peaked at 1,300 nanograms per liter. She was referred for urgent coronary angiography to a tertiary care center, but because her appointment got delayed and she stabilized on medical treatment, she was discharged, awaiting her appointment for the angiogram. Unfortunately, and 10 days later, she gets readmitted with more pain. This time the troponins remain serially negative. So she was referred to our center for an urgent coronary angiogram. The 12-lead ECG was a fairly benign tracing. A transthoracic echocardiogram revealed normal left ventricular cavity size, normal resting left ventricular wall motion, and normal left ventricular ejection fraction, which was estimated to be about 65%. She had mild to moderate degree of mitral regurgitation. The diagnostic coronary angiogram revealed moderate plaque in the right coronary artery involving its entire course in the proximal, mid, and distal segments. There was a focal 70% lesion in the mid-right coronary artery and a tight 90% lesion at the ostium of the right posterior interventricular branch. The left coronary system had quite extensive calcified atherosclerotic plaque burdening the left main, as well as the proximal and mid-LAD across its bifurcation with a large diagonal branch and the proximal and mid-circumflex. And if you pay careful attention to the cranial view, you notice that there is quite substantial tapering in the distal left main, suggesting severe distal left main disease extending to the ostium of the LAD and the circumflex. The syntax score was 44, and this was largely from the fact that this was a distal left main bifurcation, a long calcified plaque in the prox LAD with a diagonal bifurcation, and the mid LAD, and a long calcified plaque in the proximal circumflex. And based on the fact that she was diabetic, she was referred for surgical revascularization. She categorically refused CABG, and she was referred back to us to consider multivessel PCI. In planning for the procedure, there were a number of considerations that came up as listed on the slide. One of the main considerations, practical considerations that is how are we going to treat the left anterior descending? If we were come to treat it with a stent, are we going to use one long stent to cover the entire plaque in the LAD and the left main? Are we going to use two stents and overlap in the proximal LAD? Are we going to use two stents but overlap in the left main and therefore have a double layer of stent in the left main and possibly across the ostium of the circumflex, which was diseased? We had decided right off the bat that we were going to use the double kissing crush technique and thought that an overlap in the prox LAD was probably more reasonable. Were we going to protect the obtuse marginal branch? Were we going to protect the diagonal branch? She was a frail lady. Were we going to use the radial approach for access, knowing that we were going to require a 7 French guide, or whether we were going to access the femoral artery? We decided to keep it as simple as possible, and use a 7 French guide from the femoral approach, and try and keep the procedure as simple as possible. Our first step was to secure a wire into the distal LAD. Now, negotiating the plaque in the proximal and mid LAD was rather challenging. And as soon as we secured the wire in the distal segment, the patient complained of chest pain and she had ST elevation in the monitored ECG leads. We probably compromised the flow by causing a dissection while trying to wire the LAD or the fact that the lesion was so tight that our wire was occlusive. And therefore, our strategy changed a little bit, and we aimed to try and restore flow to that LAD. So we performed a gentle pre-dilatation with a 2020 millimeter semi-compliant balloon. We deliberately undersized the balloon, hoping that we won't result in significant flow-limiting dissections in the LAD until we've finished treating the circumflex. And as you can see, restoring flow to that LAD resulted in resolution of chest pain as well as the ECG changes. We then diverted our attention to the circumflex, which was wired and pre-dilated, and this was the result after pre-dilatation. This was a 2.5 by 20 millimeter semi-compliant balloon. And at this point, we thought that the circumflex was prepared well enough. So we delivered a 2.5 by 33 millimeter drug-eluting stent to the circumflex with 2 struts prolapsed into the left main. After deploying the circumflex stent, we crushed the ostial struts in the left main with a 3.0 by 20 millimeter non-compliant balloon. And there was my first oops moment, as I forgot to pull the wire out of the circumflex. I got a third wire across the crushed struts into the circumflex, and that went pretty easily. And the first wire was retrieved without any significant resistance, probably because we only had just a couple of struts hanging out into the left main. We then proceeded to post-dilating our circumflex stent with a 2.75 millimeter non-compliant balloon all the way out to the left main. We then performed our first simultaneous kissing balloon inflation with a 2.75 millimeter NC balloon in the circumflex and a 3 millimeter NC balloon in the LAD and left main. The patient just at that moment took a breath in, and as you can see, the LAD left main stent did prolapse back. However, we still thought we had enough contact between the 2 balloons, and this was the result after our first simultaneous kissing balloon inflations. It was time for us to then divert our attention to the LAD and the left main, and I was concerned that there will be significant crosstalk between the LAD stent that I'm about to deliver and the crushed struts in the circumflex, but luckily the stent went into the LAD quite smoothly without much resistance. The first stent was a 2.5 by 38 millimeter drug-eluting stent, and this was overlapped proximally with a 3.024 millimeter drug-eluting stent. The stent was placed proximally right up to the ostium of the left main. We performed the first pot with a 4 millimeter NC balloon at moderate pressure, and we flared the ostial struts at high pressure. We then post-dilated the LAD stent with a 2.75 millimeter NC balloon distally and in the mid-segment, and 3.5 NC balloon in the proximal segment. We then recrossed the stent struts into the circumflex, opened the struts with a small balloon, and ended up performing our second simultaneous kissing balloon inflation with a 3.5 NC balloon in the LAD and a 2.75 NC balloon in the circumflex. The final pot was performed with a 4 millimeter NC balloon in the left main to 20 atmospheres, including the ostial struts. And the final result was as shown. We were quite content with the angiographic result in the LAD circumflex as well as the left main. And I realized that it would have been prudent to prove adequate stent expansion and apposition with intravascular imaging, be it with IVUS or OCT. But out of all days, this was the day when my intravascular ultrasound module in the cath lab was out of order and not available for me to use in this case. How long should we then have continued dual antiplatelet therapy in this patient? Given the specifics of the treatment strategy, the fact that this was a high-risk anatomy subset, along with the DAPT score of 1, we decided to advise an extended period of dual antiplatelet therapy with aspirin and clopidogrel out to 30 months. The patient did well, and she will be called back for staged PCI to the RCA, likely FFR guided. Thank you.
Thank you, Hatim.
Yeah, thank you, Wakak. A beautiful case, الحقيقة. Let me just raise a couple of questions for Dr. Hatim. Beautifully done. Some people would advocate with this long lesion in the LAD and the relatively good sized circumflex, which you did a beautiful job on. Would you think doing a drug-eluting balloon type of focal approach and do stenting according to the results in terms of long-term would be an alternative, Hatim, in those cases?
I suppose that's an alternative treatment modality, but then I guess it also comes with its drawbacks. For one, if you end up dissecting the vessel, then you're sort of committed to stenting it, number one. Number two, with such diffuse long plaque with moderately calcified lesions in a diabetic lady, I don't know what the long-term outcome would be. I mean, she could always come back with another infection and have a more durable form of revasc performed at that time. But this was a situation where we wanted to provide her with a durable revasc. Now, I had mentioned this, that one of the limitations was the lack of intravascular imaging, and I'm pretty sure if I'd performed intravascular imaging after I'd pre-dilated the LAD, would it actually look bigger than it actually did angiographically. It was the diffuse nature of the atherosclerotic disease in the LAD that was making it look somewhat small and underfilled.
I think great job. Hatim, you still can do intravascular imaging. You said you're bringing her back for staged RCA PCI. And at that time, a lot of people are now talking about staged optimization of these vessels because of negative remodeling may improve over time. And you can you're bringing this patient back anyway, you can IVUS the left main and proximal LAD and optimize that stent as a staged procedure pretty well.
That's a beautiful suggestion, and that definitely is the intention. To ensure adequate stent expansion and apposition, particularly in the LAD and also at the left main and its distal bifurcation when she comes back. I think we're going to see her again next week sometime.
It's a beautiful idea which you brought. The thing is, how, I don't know, among the colleagues with us tonight, how many would do that? Actually, you bring them back for a staged procedure, you do an intravascular image to optimize the previously stented areas. I don't know. I mean, do you do that routinely?
I am now doing it mainly for my CTO patients, because a lot of times when you open these CTO vessels, the vessels are very small. And you bring them back, and it's not something that I've been doing it a long time. I've been doing it this year, and for the last year, where I bring back these patients and IVUS them, and more often than not, I find something that I can change. And especially, I've seen a lot of focal, not restenosis, but maybe stent compression that I can redilate, and especially the distal vessels then grow. And I can make the distal stent a lot bigger than the 2.0 it was at the beginning of the procedure. And it's lucky to work in a public setting where this is available, and we can do it without any financial burden on the patient. Hamid, you have a comment?
Well, the same, Waqar, actually. I do it for CTOs and left main. And the case I will present, I did not dwell on that, but I did CTO to the RCA when I brought them back for the osteal circ. I had to go back and check the CTO because it was long stent. And you know what? I found actually a partially a collapsed stent in the middle of the, where most of the calcium, chunk of the calcium was, that I had to optimize it before I finished the left system. But I think it's very good practice. It's very good practice if the financial cost is not a concern.
So you focus mainly.
I completely agree with my colleagues. Do it for CTO routinely. Routinely, we bring them back in 2 months. to do IVUS and make sure that because almost the majority of patients, the vessel will grow and you need to optimize the stents. And the vast majority of patients we see when we bring them back.
So from you, Abdullah, Hamid, and Waqar, CTO, left main, critical bifurcation probably will be ideal, I guess.
I guess another subset of patients in whom staged optimization of stenting can be considered is patients who come in with an acute ST elevation MI and you stent the culprit lesion. You bring them back for staged interventions and you realize the culprit vessel has grown so much. You wonder whether you need to go back and further post-dilate that stent to a slightly bigger size. That'll be another application for this strategy.
Sure.
Yeah, that's an excellent comment.